Welcome, everyone, to today's online event from the Virginia College of Emergency Physicians. My name is Jeff Kelly, and I'll be your moderator today. I'm not an emergency physician or even a medical provider, but having worked with the team at VACEP for many years, I can speak the language of emergency medicine well enough. And I'll also say you've never felt safer than when you're in a meeting room with hundreds of ER doctors. Today's webinar will review state guidelines for admissions to Virginia psychiatric hospitals and walk Virginia's emergency physicians, as well as community services boards and psychiatric hospital staff through the process. Our goal today is to stress to our own emergency physician members and their teams the importance of proper documentation to avoid blanket testing on patients experiencing a psychiatric crisis and ensure all parties operating from the same playbook and the latest rules and regulations. We'll also have time for questions, so feel free to drop them in the Q&A and I'll manage those in a bit. First, our panelists. Dr. Steve Crossman is a family medicine physician recognized for his work in global health, cultural competency, interprofessionalism, and addressing health disparities in underserved groups, including the LGBTQ community. He is highly regarded for his clinical care and teaching. He serves at Central State Hospital in Petersburg. Dr. Joran Sequeira is an emergency physician and serves as the President-Elect of the Virginia College of Emergency Physicians, representing all the Commonwealth's ER doctors, their teams, and patients statewide. I've known Dr. Sequeira and her family for several years and can personally attest to her passion for and knowledge of mental health issues. She serves on multiple psychiatric work groups and committees in Virginia advocating for these patients and their care. She helped develop the 2018 Medical Assessment Psychiatric Admissions Guidelines for the Virginia Department of Behavioral Health and Developmental Services. She and Dr. Crossman serve on the Guidelines Protocol Review and Monitoring Committee. In short, Virginians in need are all better for having them on your team. And speaking of, here's the full PRMC team here. So let's get rolling. I expect this first portion to take about 20 to 30 minutes. Then we'll have time for questions. We'll also provide this presentation to everyone, and it has links to all of these resources online. So Dr. Sequeira, take us back to 2018. You served on a team that helped develop these medical assessment admissions guidelines for DBHDS. Why were they needed, and what was the process to getting them approved for use statewide?
Yeah, thank you very much, Jeff. So basically, the medical assessment and screening guidelines that we created in 2018, it was a group of Virginia emergency physicians, psychiatrists from both private hospitals and state hospitals, as well as CSB representation. And so we all got together. And the reason why we created these guidelines is because we noticed that there was a lot of blanket testing. So I was a Virginia College of Emergency Physician Fellow, and this was my project. So a lot of hospitals were ordering acetaminophen and salicylates, TSH, EKG, and patients didn't need that, right? We had a lot of young, healthy patients that were coming in sometimes a week later. They were just discharged, and they were getting a whole bunch of testing all over again. And this was not only not great from resources perspective, right? Needing to draw those labs, get techs to do the EKGs, whatnot, but also, costly, all of these tests. And then obviously to our patients, right? Getting, these tests done every time. You have to remember that a lot of these patients are paying for these tests. Insurance doesn't always cover everything. Some of them are uninsured. Some of them are, even if they're on Medicaid or commercial insurance, there's a good amount of like co-pays and payments coming out of their pocket. So for that reason, we wanted to get together and talk about what's really standard, what should be testing that's needed on basically everybody, regardless if they're healthy or not healthy, and what do the hospitals need? And so from that came about these medical assessment guidelines. And then more, and then we also talked about, well, if there's discrepancies, if we don't agree, what can be done? And so we had the doctor-to-doctor conversation as well. And so kind of talked about like that, because what we've noticed, anecdotally, is that when we have doctor-to-doctor conversations, we can resolve a lot of issues, right? Emergency physicians, when we admit a patient, when we consult a patient, we're always talking to a physician, whether it is a cardiologist or whoever. And so for that reason, having a psychiatrist to ED doc conversation goes a long way. And then also we talk a little bit about capacity, and patients who are under an ECO don't necessarily mean loss of capacity, right? So there have been lawsuits relating to this. And so if you have capacity, you can make decisions of what can happen to your body. We try our best, right, in the emergency room. We try so hard to try to get those whatever labs or urine we need, but we can't force them, because that would be assault essentially. So, having that capacity conversation. And then finally, there was also exclusionary criteria that, that happened that both the state hospitals as well as some CSUs have. And so those were also included in the guidelines. So that was kind of a little bit of the history of it and what it entails.
Thank you. Dr. Crossman, from your perspective as the admitting physician at a state hospital, what information do you need from the ER doctor in order to move forward with an admission? In other words, how do ER physicians gain your trust?
Thanks, Jeff, and thanks for being here. I am a non-psychiatrist. I just want to make sure that people heard you when you said I'm a family med doc. And, one of the things really that I look for one of the things is, the information in the guidelines, right? So my decision making when I do the clearance, and at some facilities, it's maybe the psychiatric providers who do this, but I'm really looking for, is this person at high risk of having a medical issue happen, around the time that they get here, that we would not be able to or be prepared really to care for in our hospital, right? So the guidelines, I think, really kind of spell out a lot of that with the issues of if they're diabetic, check the blood sugar, what's the blood sugar, try to get it down before they come in. If the vitals are significantly abnormal and stay that way, what's the ED doing to kind of manage those? Or, is there a reason or explanation that they can put in and share with us about that? Are they intoxicated? And that's why I think that drug screen and the alcohol level is there. Of course, if it's a female, are they pregnant? That could be critically important if our psychiatric teams or if I medically need to provide emergency medications for this person. So the guidelines, I think, really cover the vast majority of the kind of things that I really need to see right up front from a medical perspective. Again, our hospital, Central State, is 18 to 64. So for patients who are 65 and older, or 60 or older per the guidelines, there's some additional things. And then there's a whole separate guideline for the pediatric patients, which we don't see at my facility. The other piece that's gotten a lot of airtime in terms of questioning how to do it better is the issue of COVID screening. And so what DBHDS has provided to us is a screening form that asks about symptoms and possible exposures. And if everything on that screening form is negative or hasn't happened, they're not having these symptoms, then that screening form is for our hospitals generally sufficient without the actual test, with the one exception being our geriatric facility, which is Piedmont Geriatric. Now, some of our other hospitals have geriatric units, and so those particular facilities may consider requesting that for those patients. So it's not just Piedmont; it's pretty much anyone over 65. And I think the other piece that's been really great for me and being able to kind of serve as a sub for DBHDS on this committee is getting to know some of the ER physicians, Dr. Sequeira and others that are on, having phone calls with some of our local ERs, trying to, it's not always possible. It's a big state. There's lots of ERs, but when you can and when you are able to make personal connections, I think that's, really helpful.
To that end, thank you, Dr. Crossman. To that end, Dr. Sequeira, as of January of 2023, rather, CMS no longer requires a review of symptoms in the chart. So kind of piggybacking off what he said, what do psychiatrists or family medicine physician at hospitals require from the emergency physician to give them the reassurance they need to admit without blanket testing? So kind of getting back to your comment about blanket testing.
Yeah. So, well, let's just go back a little bit to the guidelines in terms of like what is, required essentially. So, technically, it's urine drug screen, it's pregnancy test, alcohol level. On adults, we're talking adults only right now. And I know there are some places, we do CBC and a CMP. And what we've kind of found is, I've kind of been okay now getting a CBC and a CMP, even though it's technically not part of the guidelines. And partly that's just to help out the hospitals. A lot of our state hospitals or private hospitals that are just a psychiatry unit don't have access to labs quickly, right? And they use the creatinine, the kidney function test, the liver function tests to make a lot of decisions about medication management. So, and recognizing that, and doing almost like a favor, to our colleagues. I've started getting the CBC and a CMP to help that along. So I do want to mention the CBC, the CMP, the urine drug screen, the pregnancy test, and the alcohol level. So that is kind of the 5 tests that are typically, asked for and kind of required on most patients. Now, if a patient is young and healthy and just had those labs done a week ago, obviously they don't need that CBC, that CMP all over again, right? If it was normal. So just kind of putting that out there.
Right.
So Jeff, to your point about the CMS. So something that did change in 2023 that kind of affected things a little bit in terms of our charting is that we no longer require this review of systems. So in talking to one of the physicians at the hospitals, they actually used at the private hospitals, they used to look at that review of systems and say, okay, great, no chest pain, no abdominal pain, no urine symptoms, right? And no other issues. But now that's no longer there. So they really do need us to kind of ask those questions, right? Things that could potentially cause this patient to have psychosis or worsen their depression to now make them suicidal. So one of the asks that I've come to find out really from our PRMC meetings is the importance of documentation, right? So that we don't have to do blanket testing. So asking the questions and documenting, yeah, there is no dysuria, burning with urination, no blood in your urine, no chest pain, abdominal pain, vomiting, fevers, right? So those are really important to document within our note. And then another important thing is when something comes back abnormal, to explain it, right? So it's not uncommon that a patient maybe under an ACO who was struggling with police has an elevated white count, right? And so having documentation of that, white count is 14,000, likely because of, patient struggling with police, unlikely related to, pneumonia, UTI, viral syndrome because doesn't have any symptoms, asymptomatic. So having that documentation also reassures the private hospitals and state hospitals. I'll also say this is that it's, putting yourself in those other person's shoes is really important. So I can understand where the state and private hospitals are at, if they get a patient and then they decompensate really quickly. You don't want that when you've got very limited resources. So basically, those are the key things I would say is, are those things. I don't know, Jeff, did I forget anything else?
I think let's turn it over to Steve. Similar question. So, Dr. Crossman, to be clear, on your end, what is routinely needed by the psychiatric institution in order to expeditiously admit and care for a patient?
Right. And so the medical clearance and the care are a little bit different in some regards. And so I think Dr. Sequeira's point about the CBC and the CMP are, great. And that was kind of on my list down below to talk about how, if a patient comes into us on Friday at 4 p.m., we're not getting labs on that patient until the following week, unless it's critically important and we have to send them out to another ED, to get the blood drawn, because we don't have any real capability to do those after-hour draws at our facility currently. So that helping us out is hugely appreciated, and just want to thank you for that. The other real common thing. So is the patient hydrated? Right. So patients that have not been drinking enough, or have been acutely mentally ill and not able to access basic necessities, that's really important. We can't give IV fluids at our facility, for instance. So that's something that I'm really going to want to know. The basic things that the 5 things that Dr. Sequeira talked about are really important. And then, just a global sense of, this person doesn't look acutely ill. That is really helpful to me when I see documentation that says a little bit more than just patient is medically cleared. So like Dr. Sequeira was talking, if there can be a little more to that, we know that the white count's a little bit up. We think that's stress or, trauma. We know that the patient's blood pressure is a little bit up, but despite all the nurse's best efforts, we couldn't get the patient to calm down to get a calm reading. Every time it was checked, it was, kind of a struggle. So those sorts of pieces of extra information, if they're spelled out, by the clinician who's caring for them, it can be really helpful and save a lot of time. I know that one of the questions is below, are there any barriers or problems? So I just want to kind of take the chance to jump there real quick, because the ER paperwork that we get, I think everyone on the call is familiar with the massive paper dump that comes out of EHRs when you go to try to print a note these days. Back in the day, I'm old enough to remember when the entire ER course for the patient, testing, labs, meds administered, it was all on a single page for the most part. And now, we may get 10, 12 pages. The labs may be duplicated or triplicated, if that's a word, within there. The meds that the nurse administered might be hidden there. The actual provider pieces may, be a little bit hard to find. So whatever the provider can do in, the HPI or in, the assessment and plan to really kind of summarize things more than just medically cleared would be, hugely helpful.
Yeah, that's great. And Dr. Crossman started to hit on these, but as we've talked now about kind of the genesis of these guidelines, the 2 things that you all are looking for on each side. But talk a little bit about some of the roadblocks that you all are hitting. Dr. Crossman, you just hit one. So Dr. Sequeira, can you talk about some of the roadblocks and kind of the reason we're here today to gaining patient clearance?
I think with time, and especially I think COVID made us regress a little bit with like over testing, and especially, now everybody requiring COVID. But luckily that's gone away. DBHS, Steve mentioned that, but we're also working on getting all the private hospitals to not just have generic COVID testing. So that's one barrier is, we've done all the tests that are required, and then a hospital says, oh, we want a COVID test, when we know that most private hospitals and most private health systems don't require it, actually. You see who's on the PRMC. We've got representation from a majority of health systems that are like, no, we're not requiring it. We're not requiring it. And so there's a lot of miscommunication that's happening, right? And so one of the issues is that sometimes the staff and the admissions team is not necessarily getting the memo, or CSBs aren't getting the memo, or ER docs are not getting the memo, right? And so we're just still ordering all of these tests like acetaminophen, salicylates, TSHs, COVIDs that don't need to be ordered. And I think another big barrier is that just the back and forth, right? So we order what we think is best for the patient in terms of a medical clearance tests, right? If they have diabetes, ordering at least a POC glucose to make sure it's not elevated. Hypertension history, make sure it's not severely elevated. And once we get them cleared, tell the CSB and communicate that to the CSB. But sometimes it'll be back and forth with the admissions team, maybe having a checklist of their own, even though we're, saying that we're all trying to keep to this guideline. A checklist saying, no, I need to have an acetaminophen, a salicylate, whatever it is. And so basically that will be a barrier. And sometimes, again, that time delay with back and forth to people. Sometimes the barriers we see is the inability to do doc to doc. So let's just say a hospital saying we need these tests. And I'm saying, no, I don't think we need these tests. Like, this patient who has a history of dementia keeps getting CT scans of their head, and it's not indicated. They don't have any changes in their, unilateral deficits, head trauma, whatnot. And so the request is to do a doc to doc, right? And so I think sometimes ER docs don't always know that that's an ability, and I think sometimes CSBs, some don't know that this is law, right? So if an ER doc requests a doc to doc to the private or state hospital clearance person, that has to happen. And sometimes we'll see barriers where the admissions team will say, oh no, we need to have all these tests before we put you in touch with them. So that's been an issue, but what happened? But we are at the PRMC deal with those escalations and case reviews. So if that happens, there's an escalation process. And so you can always email me, Steve, if you're ever encountering that. But the ideal is if you're ever having those issues, it's really trying to get the doc to doc. Sometimes there's barriers to that, unfortunately, and the amount of time it takes. And we're trying to get everybody on board, private hospitals, state hospitals, to also get with the guidelines.
Get with the guidelines. Dr. Crossman, anything to add to that? My next question was regarding doc to doc. I think we've hit that. Anything to add on what Dr. Sequeira just said?
I'd just like to kind of reinforce the issue of the communication challenges and the time delays. So a patient in the emergency department, ED physician communicates with, CSB BHA, they need to do their eval, and then, they communicate with tons of people trying to do their bed search. And then, they might contact my admissions folks, and then my admissions folks, then in turn contact me. And then, if I have a question, and I send it back through the chain, that means, my admissions folks have to find the CSB has to find the ED, and it just can be a lot. The other communication issue that I think may be happening based on some of the conversations at the PRMC is, I may say, hey, I'd really like, let's say an EKG, maybe I find in my system the patient has a history of a prolonged QTC or something, and maybe I would like that. That request, I think, sometimes gets, from my admission team, they say, Crossman wants an EKG, and then, the CSB interprets that as, Crossman won't take the patient unless we do an EKG. And then the ED person is like, why is Crossman telling me what I need to do for this patient when I'm the one who's actually taking care of them and I know what the clinical state is? So, sometimes that request for something gets reinterpreted down the chain as a requirement when maybe it didn't necessarily start off that way. I tend to get impatient, and I have the advantage over Joran because I know where the patient is. I know how to get a hold of her. She doesn't really necessarily know where I am or how to get a hold of me. So sometimes, especially if it's something that probably is quick and easy, I'll just call the ED directly and say, can I talk to the provider? I just want to clarify this. Once you get through the hospital's phone tree, transfer phone call challenge, once that challenge is overcome, which, can take a while and multiple calls sometimes with certain hospitals, then things usually go much more quickly. Like Dr. Sequeira said, once you actually get the two providers talking to each other, 'most things in my experience can be, resolved or we can understand each other better, and we can kind of move forward.
The
Yeah,
importance
and I will
of,
say, like,
yeah.
my heart goes out to like the CSBs and the admission teams too, because you guys are kind of stuck in the middle sometimes, or most of the time, right? You're stuck in the
All
middle
the time.
all the time. And, and I recognize that it isn't within your scope to like know the medical jargon and the medical stuff. And so that is why, Steve, myself, the entire PRMC are very much promoters of getting the doc to doc to happen. And if you have to state like, hey, it's law, if anybody's refusing, so be it. But that really does improve a lot of movement forward. And I will also say, like, if the psychiatrist is super easy to get on the phone, but the ER doc is harder, get the ER doc on the phone first, and then get the psychiatrist on the phone. Just because sometimes I've heard that it's also hard of getting both, as Steve mentioned, on the phone kind of at the same time. So yeah, trying to do that as much as possible is key as well.
Right. Like anything, the importance of communication. I have one more question for our panelists. Before I do, as a reminder, if anyone, any of our attendees have questions, go ahead and drop them in the Q&A. It's on the bottom of your little Zoom window there. I'll take the questions and throw them to the panelists. Dr. Sequeira, Dr. Crossman, before we adjourn here, is there anything else you would like to add regarding this process?
I would just say, I think the big thing here is, I think over the last couple of years, I think we've kind of enabled more testing to happen, and partly because we don't want to delay the patient's admission, right? We're all trying to do the best thing for the patient, truly. But I think what has happened is, when X hospital is asking for tests and this one's hospital and this one and this one, we kind of are like, okay, just to save time, so we're not waiting another hour for this test to come back or another hour for that test to come back. Let's just order all the tests up front, right? And I think we need to kind of have a reset as a state of, okay, we really shouldn't be doing this. We should really be only ordering tests that are needed. And it's interesting in being a part of these meetings and hearing from the private hospitals that are saying, no, we don't need that test. No, we don't need that test. I think it's just with time, we've just kind of formulated these blanket tests. So my hope is that we just all do a reset. We all, trust the ER doc to order what they need to do, and sometimes if the CSBs, I understand, sometimes the doc doesn't always do the thing that they need to do and get that glucose on a diabetic patient, or document why the vitals are, why they're very hypertensive or tachycardic. So, I think it's a team, like we have to help each other and kind of set each other up for success in terms of that documentation and such. So that's basically the ask.
Yeah, and I just want to kind of reinforce, I've learned a ton by being able to be on this committee, and the fact that the CSBs are having to do a statewide bed search. So, all it takes is one hospital to require something that's above and beyond the guidelines. And then it sort of becomes, almost like it needs to be done for every hospital, because it's like you don't really know in advance kind of where the patient's going. So I think that, hopefully this session will be able to kind of help in that reset mode post-pandemic. Can we get back to really the systematic guideline-based approach to this throughout the entire state that was really, started back with these guidelines in 2018, 2019. I just also to share, I think, like Dr. Sequeira said, everybody wants the patient to get the right care in the right place at the right time, by the right provider, and be safe. And so, I think recognizing that we're all aiming for the same goal, and then kind of coming together to figure out how to do it most efficiently. I think that's what these conversations are all about.
It's great. Thank you both. We did have one question come in for the doctors here. How would you all advise when a CSB is insisting they won't start an assessment or referral until the labs are done?
So when it comes to that, like, so I think that's a conversation that the medical director will have to have with that CSB director, right? The emergency services director for that CSB. So we've talked a lot about this at PRMC that shouldn't be happening, right? I recognize maybe with certain things, like especially in older adults or an ingestion, right? You need to clear them first. And so there it makes sense for maybe labs to come back first. But again, those young, healthy patients that you're waiting for the CBC or the CMP on, the tests, the referrals, the assessments should get started. I also recognize that a lot of these admission places won't really listen even until that all happens. So I know that the CSBs are stuck between a rock and a hard place. So basically, I don't know, Steve, if you have any ideas of like, do you think that they should be waiting for the labs to come back before starting the referral? Because I know a lot of these places require the test, to know whether or not they can move on. I think in the future, though, there are plans coming to kind of hopefully get to a system where it's all electronically done and there's not this faxing system, right? Because if we can get to a point where we don't have to wait for labs and such, but we can start to talk about what resources are available. Like, can you take this patient with a PEG tube, a G tube, or not? And then either deny or be able to accept based on that. Like, that's what they really need to know.
And again, I think that it goes back to what you were talking about, Joran, is the emergency provider making some judgment calls. So for instance, if it's a patient that, you're trying to figure out, is it delirium, which is, technically an exclusionary criteria, I think. Yes, acute delirium. So that kind of thing where, maybe you do need to have the labs first to see if they are appropriate. But otherwise, the young, healthy people, I would agree that it would be, potentially okay to kind of start the train rolling if there's nothing really indicating that, something is really off. I think another, challenge, of course, is that while we have the exclusionary criteria, there are facilities that can and can't do certain things. So even within the state system, there's a pretty significant variability about what facilities are able to provide what services, such as oxygen. The other issue that we come across a lot is the secure units. So with forensic patients, many devices or equipment that might seem to be, typical in a hospital could be considered contraband on some of our secure units and, wouldn't be allowed. It goes the other way too. Sometimes exclusionary criteria don't quite, make the patient unable to come here. So for instance, we had a patient who was on hemodialysis, and that's an exclusion criteria. We can't deal with that here. However, in talking with the referring site, which happened to be a jail, we worked it out and we were able to admit the patient through that communication and networking with community resources and all those things. There are a few other thoughts, I think, in the Q&A, Jeff, that have kind of come in.
Yeah, so I saw one thing about peds. So because we didn't really address pediatric patients and what kind of tests they need. So I will say less than 12 years old, really shouldn't be needing any tests right there right now. So we've got a representative from CHKD on our PRMC. There's even talk about, 12 to 17, how much testing we need. But, right now it's a urine drug screen, maybe an alcohol level if they, have any history of alcohol use. But less than 12 really doesn't need any testing. And so it makes sense when the doc is refusing to do tests on children because they think it's too invasive. It causes PTSD. Like kids get really scared of hospitals already and needles already, right? I mean, adults do too. It can be really traumatic in a kid. And so we try to avoid any tests. And so what we do in that case is if a hospital is asking for tests, again, it's a doc to doc. Now, VTCC, CHKD, they've all agreed that patients don't need labs, if they're, young kids do not need blood work. So if that's happening, if you're hearing about that, please let us know, but escalate, don't force it on that kid.
And I guess the the comment about the pregnancy tests on the patient with the hysterectomy, one of the mantras that's been kind of drilled into my head throughout all of my medical training is that when the patient absolutely positively assures you that they can no way be pregnant, get a pregnancy test. And I think that, I don't know this case specifically. If there is, documented an op note that says they had the hysterectomy and they have the scars and all that kind of stuff, and someone's still demanding it, then, like Dr. Sequeira said, escalate that to the PRMC. The other comment that I thought is really interesting is, we're asking at the PRMC to get feedback, for everyone, the CSBs, the ERs, when they feel like there are barriers that are being put up or that people aren't, respecting the guidelines that were created. But the final comment, I think, if I'm reading it right, suggests that, the psychiatric hospitals, maybe they should be providing some feedback to the EDs and the CSBs. So I think the example in the comment was, it looked like the person was okay, but, when we ended up getting their sodium, it was, super low. And they didn't get a CMP, maybe. So I think that that's a great idea to kind of, make the communication and the feedback loops work both ways. And Dr. Sequeira, as chair of PRMC, can kind of maybe think about that with the committee if we want to be the central spot for that or not. But figuring out that process, I think, could be good too.
Agreed. Right. So I will say, as an ER doc, we admit patients all the time that then, unbeknownst to us or sometimes beknownst to us, they decompensate. Sometimes you can't predict it, right? Sometimes things reveal themselves later. And so it's not uncommon, right, that patients go to the floor and then they decompensate, go to the ICU. And so we do get feedback from on a hospital level of, hey, was there anything that we saw that could have predicted this patient decompensating later? We don't get that, as much when we transfer patients, whether it's to psych or other hospitals. And so it would be, I agree, it'd be wonderful if we got that feedback, because the last thing we want is to overcompensate, right? Overcorrect. And sometimes I think our system and our health systems are very easy to kind of overcorrect at times and say, okay, well, this person decompensated, or they had a seizure, we're now going to, blanket test and do this every time to avoid this happening again. That's not the right move, because it does nothing, right? Individual feedback is really where it comes down to, because that clinician, that physician or APP in the ER is still continuing to make that mistake. If it is a mistake, let's just say, if they're not doing appropriate clearance, then they'll continue to do so and nothing's changed, right? So it's really important that we do give feedback. And as Steve said, we can consider it coming through PRMC. That's totally fine. If you want us, necessarily stay anonymous and say, and talk to us about the case, that's totally fine. And we can, reach out to that individual. Because the other thing is, we are already doing that the other way, right? CSBs are already reaching out to us. ER docs are already reaching out to us saying, hey, I had this issue, I had this barrier, and then we have the means to then individually reach out to those locations and say, tell me what you were thinking, tell me what was happening, do you know about these guidelines, and educating. So if it goes the other way, we would love that too, right? Because everybody wants to be better. Everybody wants to do the right thing for our kids.
Right. Well, thank you both, Dr. Sequeira, Dr. Crossman, and thank you everyone for joining us today. It was a big crowd on this call, which really underscores the importance of this issue. And on behalf of the Virginia College of Emergency Physicians, we really appreciate everyone's support. We will send this recording around and presentation sometime next week. I just need to package it all up. Please share what you've learned today with your peers. And like Dr. Sequeira said, let's get with the guidelines. So thank you all and have a great weekend.